Uh, Actually, it's a cluster of conditions which till 2014 didn't even have a proper classification. It's called variously as myofascial pain dysfunction syndrome or atypical facial pain, chronic facial pain, take your pick. But it's generally myogenic pain, pain that originates from the muscles of mastication. The etiology is poorly understood, and it has been classified into these 5 different subclassifications. And the diagnostic criteria is a combination of history and clinical examination, which the slide shows. And this is what the 2014 International Association for the Management of Pain has decreed it to be. We will be talking about myofascial pain, and which is pain which is limited to the muscle of mastication. It can be referred, but it usually does not cross the boundary of the muscle. The etiology of myogenic pain is very poorly understood. Bruxism, which is repetitive grinding of teeth, especially happens at night, but it can happen in the daytime as well, nocturnal and diurnal. That is a major causative factor. But we still don't know the pathogenesis. We don't know how actually it happens. But we have some theories. And the theory is that maybe the muscle hyperactivity, which can cause masseteric hypertrophy, can lead to direct pain. The other theory is that inflammation in the muscle fibers can lead to pain, but these are generally just theories. The etiology of bruxism, that also has 2 further theories, which can be, some people say that it is because of the condition of the position of the teeth, the malocclusion, how teeth contact each other, or how they do not contact each other. And one of the treatment modalities, which is very commonly prescribed on NHS, targets theory number 1, which is the peripheral cause, malocclusion. That is that teeth contacting not correctly cause TMJDS. There is no evidence for this, but we've been doing it for years. The second theory is central disturbances in the basal ganglia, which can cause bruxism. Again, we don't know much about it. There is very low level of evidence. We talk about management. Management, which has been gold standard for quite some time, it sometimes works, sometimes doesn't, the roll of the dice. We have supportive measures, we have physical therapy, we've tried everything, and like for every therapy, we always try lasers for everything. And these are the various ones. My next slide, we have had some evidence which says biofeedback can help, but it is completely a different realm. We have to refer patients to hospitals, and they will have to go through the loop of accessing the CPT. The non-pharmacologic pain management, which for years has been used, which Cochrane reviews show no evidence for, are the splints. Splints are the kind of plastic things that you wear in your mouth, which change the different contacts of your teeth. It sometimes works. First, we start with a soft splint. It costs the NHS about £240 to £300 each splint. If it is soft, if it is hard, it costs a bit more. Then you can have flat plane splints in which there are no teeth contacting in different areas of the mouth. Or you could have mandibular repositioning splints, which cost much more, about £500. And the only evidence that says that they can provide a little bit of protection to the TMJ against wear. That's about it. But whether they break the habit or not, we don't know. Most of the times, people are on these splints for life. They get rid of the splint, and the pain reappears because they're grinding, the chewing, or the central disturbances, which we know little about, they return. Pharmacological interventions have been many, but there are really only 2 medications which help, and that also for a short time duration. A Cochrane review found no evidence for any kind of NSAIDs, any kind of sleeping agents, antiepileptics, anything. But the only two medications that seem to help are naproxen and amitriptyline, and these are the double-blind RCTs which establish that, and they are used currently only for short-term relief of pain. That's it. Another treatment that has been done previously and is being done is currently done in smaller quarters, but it targets the etiology in the manner that we understand it. It is basic botulinum toxin, which we all know about, and we all know how it works, and we all know that it causes partial muscular paralysis. But it does a bit more than that. That is just one of the things botulinum toxin does. I'm not being paid to speak here by any botulinum toxin companies. Let me just make that clear. So I'll just tell you that it works by cleaving the SNAP25 enzyme and prevents the acetylcholine, which is the transmitter, from coming out of the neuron. But it also prevents very powerful neuronal mediators of inflammation like substance P, like calcitonin gene-related peptide, and glutamate from the same thing. So a reduction in the inflammatory mediators may prevent pain, and that is what is also seen in conditions in migraine, in tension-type headaches, where these mediators are involved. So we have a blockade of neurotransmitter release, and we have a blockade of pain mediator release. So these are the two modes of action which we think that it works with. So the first of one targets the first theory that we have for bruxism, and that is the hypertrophy of the muscle, the overworking of the muscle theory. So if you have a neuromuscular blockade of the muscle, then you get that muscle out of action. So a patient cannot grind for 4.5 months. So the habit breaks, there is disuse atrophy of the muscle of mastication, and the negative feedback mechanism breaks down, and they don't go back to grinding, which they do with splints and with the other kind of things. And the other one is the analgesic effect, which we think it may act as, but again, much more research is required. We have some studies. These studies have mainly been done in the US, and they have found positive results, but we need many more studies, randomized controlled trials, etc. I'll just show a few cases. I'm coming to the end. We have our first case, a 26-year-old lady. She is actually an NHS manager, so she does suffer from stress. We shouldn't be surprised about that. And this was a lady with recurrent pain in the TMJ, 3 years duration, mesenteric hypertrophy, two instances in which she has had splints and other therapy, no respite. Botulinum toxin treatment we did. We got her mesenteric hypertrophy down, and she has been pain-free for 3 years. Next case, we have a 38-year-old lady with similar complaints. She's not an NHS manager. She appeared with pain that wasn't going with any kind of intervention, with these kind of masseters. We did the treatment. 6 months later, her mesenteric hypertrophy had gone down. There is no recurrence of pain. A 34-year-old professor, a very high-powered professor, one of my typical cases. She has had this problem since she was 19, since she was a student in university, and she came to me after 12 or 13 years of enduring every kind of possible treatment that you can think of for her, like grinding. She used to get a big pain, severe pain. Her quality of life was poor, and she had been treated for 2 years at Imperial College of London with exercises, with splints, with everything. These were her masseters, completely in distress patient. And after 2 courses of botulinum toxin injections over a period of 3 months, we got it down here. No pain in the last 3 years. So if possibly more research can be done, we can find more of such results, more evidence, maybe on NHS it can be. Thank you.